We're having a session on PMBV, PTMC, and indications and procedural tips and tricks, which Dr. Mohammed Ramzan has worked hard on this talk and is going to be presenting it. And we have an excellent panel with Dr. Asad Pathan from Tabba Heart Institute. He's doing PTMCs over there. And then Dr. Mohammed Irfan Saab, who's assistant professor in Lady Reading Hospital, and he's doing involved with this as well. So it'll be good to get their insight from these two. And Dr. Tariq Abbas will be joining as well shortly. He's heading the Chaudhry Pervez Ali Institute of Cardiology. And our president of the society, Professor Zubair Akram Saab, has also joined us. So he'll also be giving in some closing remarks regarding the procedure. So without any further delays, I think we should get started. So Dr. Ramzan Saab, the stage is yours. Shuru kar dein.
Thank you very much, Professor Manasi. And I would like to thank you and PSIC, my department, and my Professor Tariq Abbas for providing me this opportunity to discuss different aspects of this PMBV procedure, including the indication, the imaging guidance, and different procedural tips and tricks. I'm Dr. Mohammed Ramzan, and I'm working as the Assistant Professor of Cardiology at Chaudhry Pervez Ali Institute of Cardiology, Multan. We all know that in our country, rheumatic heart disease is quite common, and it is compromising the quality of life of especially many of the young people. And in this regard, PMBV is quite an important therapeutic tool in the management of mitral stenosis. It should be learned by our fellows, and it has a very steep learning curve. So we have to be patient to learn this skill. Regarding the indication of the balloon valvoplasty, according to the AHA, we all know that patient with rheumatic severe mitral stenosis in stage D, I think means they are symptomatic, have a pliable valve with no clot or significant indication for PMBV. And if the patient is asymptomatic in stage C and still the valve is pliable with no clot or significant MR, and if patient has got pulmonary hypertension, then this is class 2A. And if a patient has a new onset of atrial fibrillation, then it is class 2B. Along the indications, important contraindications should be especially the MR and the commissural calcification when it is severe. And also, if the patient has got concomitant other severe valve disease or the ischemic heart disease requiring bypass surgery, then this procedure should not be performed. For the clinical fellows, I would like to discuss few tips and tricks regarding the assessment of the mitral valve. And one thing is when we are assessing the severity of our mitral valve, we should keep in mind that pressure gradient is a variable, especially in the presence of high output states. Solely on this parameter regarding the severity. The other parameter is the pressure half time. Again, it is also affected, and I would like to discuss only two tips in this regard. One is that post PTMC, we should not follow this pressure half time process, the mitral valve area, especially first 48 hours because of the abrupt change in the LA pressure. And the other important aspect is if the curve is bimodal, you can see in this picture over here, then we should be careful while doing this pressure half time. We should not take the first peak, rather we should take the later part of the deceleration slope, which is I'm just delineating here with the red line. And if the patient has got atrial fibrillation, then we should also be careful and we should take the pressure half time in multiple beats. The third aspect is the planimetry. Of course, it does, but it needs an experienced operator. And the most important thing in this regard is plane should be perpendicular to the orifice. You can see in this picture, if we slightly move towards the LA, the area markedly increased. So this can only be possible by doing with the 3D probe with multi-dimensional imaging. We should put the perpendicular cursor over here in the parasternal long axis, and we will simultaneously get this short axis view with the nicely delineated and planning the area. And the other important thing while we are doing this, we should take it in the mid diastole when the valve is fully opened. And to the fellows, we should include the open part of the commissures as well in our planimetry. Only then we will get the accurate mitral valve area. 3D Pro can also help us to see the valve, and we can measure the area as well. From the LA aspect as well as from the LV aspect, we can see the morphology of the valve. After the severity assessment, we go for the suitability of the valve for this procedure, and different scores we use. One is the Wilkins score, other is the Carnier, and the third one is the commissural calcium score. Most is the Wilkins score, and here the four parameters are being assessed. One is a leaflet thickness in diastole, and it should be less than 5 mm for the suitability. The other parameter is the mobility, then the calcification and the caudal thickening, and the shorting is the fourth parameter. Maximum score is 16, minimum score is 4, and if the score is less than 8, then this valve is good for for this procedure, and the outcome will be good. And if the score is between 8 and 12, that's this a gray area, and we may get better results. And if the score is more than 12, then of course the results will be poor and the complication rate will be quite high. So I'll share a case with you to assess how we calculate this uh, Wilkins score. You just you can easily appreciate in this parasternal long axis view in this young lady, the mitral valve is stenosed, severely stenosed. We can assess the thickness, but I measured in diastole was 4 mm. Just hardly the valve is restricted at the tip of the mitral AML. So the thickness was 1, mobility was score was 1. There is a hardly a speck of calcium in the AML, which was also scoring the 1. Color Doppler interrogation was showing a mild eccentric MR. This is shown in this view. There the tachymetry in the area was 0.9 centimeter square. And you can see I included the open part of the measure as well. So this is the subvalve part of this patient. The subvalve disease was measured, which was 1.57 centimeter, and I'll also measured this in with the 4D probe in the as well. And there is a hardly a one speck of calcium in the AML. So the total score was hardly 5 to 6 in this lady, and her valve was nicely suitable for this. These are the four different valves in other patient, which we see. You can see these all the valves are pliable for this procedure, but they have got some different scores. In the short axis, you can appreciate the calcium, and this is the modified three-chamber view. Again, the valves are good with some variable score, and the results were good at the end of the. You can see in this case, here the valve morphology is not good. Mobility is restricted. Thickening is more than 8 mm. The calcium is quite high, around 3. Subvalvular disease, you can appreciate in this parasternal long axis view. This is, and they are shortened and making the score around 3. So this valve was not suitable for this procedure, PMBV. The other important score is the commissural score, which is the Sutaria score, and this score ranges from 0 to 4. And two commissures at 3 and 9 o'clock, the postomedial and the anterolateral commissures, And these commissures, actually, we are doing the commissurotomy. So the commissures should be free of calcium for our successful procedure. As the calcium will increase, the success chances will be less and there will be more chances of the calcium. You can appreciate in this panel B that the calcium is quite high in the anterolateral commissures. So outcome was not that much good as in the case A. So once we have done all the workup for this patient for the suitability of the valve, what we do is after getting the consent, we routinely do the routine investigations. We perform the INR, especially the patient is on the anticoagulations, and we shortly NPO patient for our TOE procedure to rule out the LA appendage clot and to further assess the mitral valve anatomy. So LA appendage in this case was free of the clot, and we assess the interatrial septum in this bicable view. You can easily appreciate the thin part of fossa ovalis and then the thickest muscular part around anterior and the posterior aspect of the septum. We can easily appreciate this interatrial septum on the 3D echo as well. And from the LA aspect, this septum looks like this. The color Doppler interrogation for any mitral valve regurgitation. And this is another patient for the LA appendage clot, and you can appreciate the dense, spontaneous echo contrast into the LA and LA appendage as well, but no definite clot. So this is the classification we use for the LA application. LA appendage clot, what they said is this is not the absolute contraindication, especially if the clot is confined to the LA appendage. We can take some few precautions not to touch this clot, but we can perform in type 1A. Otherwise, it's a contraindication. These are the different clots which we can daily practically appreciate on our TOE procedures. And on 4D, the LA clot appears like this. After doing this T, the first procedure which we perform is the septal puncture. And this is quite challenging, and I will try to make it as simple as possible so that the fellows can easily understand the basic concept of how we perform safely this septal puncture. First is this history of this puncture, septal puncture, which was started way back by Dr. J. Ross from the 1959. And since then, it has evolved through for the many procedures. Initially, it was just being done for hemodynamic assessment, LA and LV pressures. But in this PMBV procedure was started, only vein isolation on the left side was done through this septal puncture. Then Watchman device for LA appendage occlusion and left ventricular assist device was also used in 2003. In 2006, mitral parabol leak repair was done through this septal puncture. 2008, mitral clip, and in 2012, the transcatheter mitral valve replacement also done through this septal puncture. So this is very important to learn this septal puncture. So we do it under fluoroscopy with the help of echo guidance. Echo, we either use the transesophageal echo. So this is the toolkit for the transseptal puncture, Mullen sheath, which is optional. Many of the operators, they don't use, they just use the dilator. And the third is the broken bro needle. This is the different various aspects of the broken bro needle. The proximal part having an indicator, and it is 18 gauge and gradually it tapers to 21 gauge as we move distally. Apart from these three, sheath, dilator, and the puncture needle, we also require the O25 guide wire, pigtail, and the multi-purpose catheter. First of all, we get the access from the right femoral artery and the vein. This is the septal interlateral septal anatomy. We all aware of this. And these are the conventionally to find out the proper place of the transseptal puncture. Initially, the Hanoi method was used. In Hanoi method, we used to give the contrast in the LA, and after giving this contrast, we mark this tricuspid valve, where the tricuspid valve is. And then we wait the levo phase and to come this contrast into the LA to mark the outer border of the LA. And then we draw a horizontal run from this tricuspid point out to the outer border of the LA. And this horizontal line was drawn was equally divided through a vertical midline, and this midline basically was being achieved through this Inouye angiogram methods. Later on, the other M line is quite common in both Inouye and the Hung's method. I will discuss later. Later on, what Hunks did, he just replaced this RO angiogram with the pigtail catheter, putting in it to the non-coronary cusp of the aorta, so that he makes the life a bit easier. I will practically show how we draw this midline. So we put our pigtail catheter into the non-coronary cusp of the aorta, and you can easily appreciate the outer border of the LA. So we draw a horizontal line from point A to LA outer boundary, and then we divide this line equally through a vertical midline. So this is the vertical midline, and then we will go to the RA view, putting our pigtail into the LV, and we will perform an LV angiogram. Why? To get this one. We will first delineate the mitral valve annulus, and from this mitral valve annulus, we draw a horizontal M line towards the spine. And we will calculate to which vertebra this line is intersecting. And practically, you can see over here in our patient, we did the same thing. We did the LV angiogram, we delineate the mitral annulus, we draw a horizontal line, and it's stretching the T10 vertebra. This is how the M line is drawn in both Hung as well as the Hanoi method. So these are the two lines, and we can easily appreciate. Now, where this M line will intersect with the midline, that is the our puncture target. This is the M line in RA view, and this is the midline in frontal view, and this where it will intersect, this will be the puncture site. After appreciating the landmarks, we will assemble our transseptal kit, sheath, the dilator, and the needle, and we will put a finger in between the needle and the dilator so as to safety purpose not to puncture any other structure. We will start in the AP view, and from the left innominate vein, this is our multi-purpose catheter. And then this is the assembly. We will gradually draw this assembly, and we can appreciate in most of the patient 2 or 3 jumps of this assembly. One is from the SVC to RA, and the other is from RA to fossa ovalis. Then we will move to the RA view to confirm our point. In RA view, if you see on the right side, this is the fossa ovalis point. So that means my needle should be posteriorly directed, and it should be between spine and the pigtail catheter. And this is what I appreciated in my patient. This is what our EP people also delineate. This is the RA view where the sweet puncture point lies. So this is our lower boundary is marked by the coronary sinus, by the CS catheter, and the upper boundary is marked by the horizontal line from the pigtail, anterior boundary by the anterior border of the RA by the aorta, and the posterior boundary by the posterior wall of the LA. So this is a window we can puncture the septum. Well, many people do in LAO 30 or RAO or the frontal, but we are usually we are trained in to puncture the septum in lateral view, and this is the line, this is the pigtail, this is the spine, and this is the line in between, and we should puncture this approximately in the middle 1/3 of the part where our needle will be pointing posteriorly. So once we have punctured the interlateral septum, we just hold our needle over here and we do not advance our rest of the assembly into the LA. First, we will confirm whether it is LA or not. So this can be confirmed by giving the contrast. The other method is by checking the pressures. If I put the pressure line back of the needle, when I in the RA, the pressures will be like this. When I touch the septum, the pressure becomes flat. And soon as I enter into the LA, I appreciate the pressure in the increased pressure in the LA. So this is how I can confirm that I am in the LA. So then I will move into the RA view and I will do the LA angiogram. So this will assess whether my puncture is low, high, or ideal, and also where the mitral valve lies and where the LV lies. So it will help me to cross the mitral valve later on. Then I will take the pressures from the LV as well as from the LA. And you can see that the LA pressures are quite high. Peak pressure is 39 and the mean pressure is 32. I can take the help of we can take the help of a transesophageal to much safely perform this puncture. And two views are used. One is the bicable view. You can see the tenting by this needle in bicable view, and other is the short axis view, where anterior posterior aspect of the septum and again the tenting can well. Uh, Not in routine practice, intracardiac echo can also be used. This is a 10F catheter through the 12F sheath. From venous system, we enter into the RA and then easily again we can appreciate the tenting by the puncture needle. This is how we can take the age of the imaging and can safely perform the septal puncture. So once we have entered into the left system, we should give the heparin to the patient. And this is being done 100 units per kg to achieve to 300. But this doesn't happens always that we can easily puncture. I used to say every PTMC is a new challenge. So the difficulties can happen while our transseptal puncture. This could be because of the severely enlarged LA or RA, or because of the aortic root aneurysm, kyphoscoliosis, post-heart surgery, or severe RV or LV enlargement, or even in pregnant ladies, we also face some difficulties. So in all these scenarios, we can take the help of transesophageal echo or the intracardiac echo to perform a safe septal puncture. New technologies has also evolved to make this puncture easy and one is the NRJ uh, frequency needle, which do not you need any mechanical force. The other is the steerable flex point needle, which can be the shape of this needle can be changed by knob by this knob. And the third one is the Versa Cross or radio frequency wire. So are all these systems can also be used to achieve a good transeptal puncture. This is the PTMC tool, a ruler, a 14F dilator, the annoy balloon, LA guide wire, spring stylus, and the balloon stretching tube for the annoy balloon, and of course the syringe. This is the annoy balloon. This is a 12F balloon, and it comes in different sizes from 20 to 30 mm. And this is by and the size of the balloon is used by using the formula of the patient height divided by 10 plus 10 conventionally. And what the interventionist should consider is when the valve is calcified, inflation should be done at relatively low pressure. And when there is extensive subvalve disease, balloon of slightly lower size should be selected. And if the valve thickening is more, then we may need high pressures uh, to split the commissures. And we should also keep in mind that we should give sequential inflations rather than a single inflation. So this will give us better results and we Entering into the LA, this is the LA wire, and the dilator is over the LA wire to dilate the interreceptor tract for the balloon. Then this is how we slide the balloon over this LA wire into the LA, and we remove this LA wire. From this point, we will move to the RAO to cross the mitral valve. You can see I am now in the RAO view, and now I will move my spring stylus slightly anti-clockwise, full balloon slide, it start bobbing towards the mitral valve orifice. And then I will just pull the stylus and push the balloon to cross the mitral valve like this. It has nicely entered into the LV, and it is moving freely without any angulation or entanglement. But most of the time it doesn't happen, especially when we do the low atrial puncture, or the LA is quite large. We have to use this reverse loop entry as well by clockwise rotation of the stellate, and this is how we enter into the mitral valve from the floor of the valve. Very rarely we need this veno arterial loop to cross the mitral valve. If the valve is calcified, severely stenosed, and our balloon is unable to cross, so what we do is we do use the pterygium wire to enter into the LV, and from LV into the ascending aorta, and then we will just snare this wire through the arterial sheath. And then if the balloon is crossed, well and good. Otherwise, we will take a small peripheral balloon to pre-dilate the mitral valve. And then we will cross through this Inouye balloon and will do the proper dilatation. So this is how the sequential dilatation is done. First, the distal part of the Inouye balloon is inflated, and then we pull the balloon across the mitral valve, and then the proximal part, and ultimately the thick mesh part of the sleeve is inflated to stretch and split the commissures. So this I was talking that we should be aware that our catheter should be moving freely in the left ventricular cavity. There should not be any angulation or entanglement. And the other thing is this impasse sign you can appreciate in this picture. This shows the subvalvular disease, and we should be careful. Look at this. Rather than to inflate the distal part, the proximal part is inflated first. We should be careful of this. And this is the entanglement. Look at this procedure recently done. The valve is not properly in the long axis. So when we inflated the distal part, taken the shape of this, we did develop a significant MR in this patient. So we should be careful about if balloon takes this shape, we should deflate and again re-enter into the LV in some different suitable plane. These are the post-PTMC results. You can appreciate the valve is nicely opened, and color Doppler interrogation shows the MR1 plus, which is eccentric, and planimetry showing the area which has increased from 0.9 to 2 centimeters square. These are the successful criteria which we usually appreciate. At least one or more of the commissure must be splitted. Area should be increased around 50%. LA pressure should be reduced by 50%. And transmitral gradient should be reduced by 50 to 60% cardiac output, DR, and there should be no procedural complication. And or of course, the mitral valve regurgitation should not worsen. So these are the major complications related to the septal puncture. I will discuss later on. MR is the most common complication in 15%. Out of that, 2% patient may need urgent surgery. And this MR usually happens because of the tearing or stretching of the commissures, failure of the leaflet coaptation, rupture of the mitral valve leaflet, rupture of the chordae, or damage to the capillary muscle. This is the nightmare in the cath lab. If we puncture the aorta, then of course, and also put call our surgery fellow. In some cases, people have did close successfully with the VSC device as well, this aorta puncture as well. The other septal related complication is the stitch effect. This can happen usually when the LA is quite enlarged. We can either enter from interradial septum, as you can see in this picture, interradial septum, then into the pericardial space, and then into the LA. Or we can first puncture the RA, then into the pericardial space, and then we will enter into the LA. This sealing effect will remain till the completion of the procedure, and then as we will draw our equipment, withdraw our equipment, then the patient may end up in the tamponade. So surgery may require or the device closure may require in this patient. So we should carefully keep in mind while we are withdrawing our apparatus from the patient. With this, I conclude my talk. Thank you very much for your kind attention.
Thank you very much. Excellent talk, Dr. Mohammed Ramzan. You covered all aspects as we discussed, starting from the indications showing on echo as to how to assess the valve for the PTMC, and then showing step by step how to go with it along with the complications. So well done, showing images. And so it was a really nice talk. Nicely done. Loved it. So, my question was that, in US, all the transeptals that we do are TE guided. And is there any reason, and now they're using the VersaCore radio frequency thing, and those things do make the procedure safer. With the TE guided, it's very useful. You can use traditionally the bicable to assess the superior inferior relationship, and the four chamber to assess the height of the puncture, and short axis to assess the anterior posterior position. And based on that, you can be, depending on the procedure, you can choose your puncture site much more accurately. So any reason that we are not using T as frequently for these, for PTMC as well? And I'd like you to answer it, and then take an answer from the panelists as well on this question, and then have their comments as well.
So what I have appreciated at my center even that this procedure, if we include the T, this need general anesthesia. For that, we need an anesthetist, and as well as we need a separate operator for the T to operate this T. So
Yes.
because of this, it takes a lot of time. So that's the reason we are actually doing it without this transesophageal.
All right. So now I'll get
Noman, if I can answer that question a
Please,
little bit.
Go ahead, yeah.
I think as Ramzan said, cost is a big issue. I'll just say like in her institution ki cost alag hai. But at Tabba Heart Institute, initial ventilator, you can't do a TE for a PTMC without GA, mainly because aapne bhi dekha hai, patients are coughing, moving around, and you can't have that if you're doing a transeptal or if you're putting an ASD device. So it's not like a diagnostic TE, you can do it just with moderate sedation and topical anesthesia. So you need general anesthesia. Tabba mein initial circuit, vent ke and tubing, priming, anesthesia cost is immediately about 60,000 rupees. और उसके बाद आप टी की cost डालें another 15-20,000 rupees. The cost is a big issue. दूसरा USA में earlier on it was lack of expertise because in Pakistan, India, आप NICVD चले जाएं वहाँ पे daily, and I'm sure Punjab में भी some centers में होगा कि daily several PTMCs are being done. So the level of experience is different, although USA may be because of all these newer procedure. But the most important thing for this newer procedure, and I think even for PTMC, targeted transeptal puncture karna hota hai. You not randomly, it's not like you have diagnostic transeptal puncture kar rahe hain, you just get into the LA any place and you're good. So you have to do a targeted transeptal puncture, and even mitral valvuloplasty mein aap kaun si technique use kar rahe hain. If you're using double balloon technique, position alag hai, NOA ki position alag hai, you have to be a little bit more inferior and posterior for your puncture. I think jo Ramzan dikha rahe the, in the RAO view, I think the puncture was quite anterior. And if you get a good transeptal puncture for PTMC, and हम पाकिस्तान में invariably in a way use कर रहे होते हैं, your balloon crossing and the rest of the procedure becomes very simple and predictable. So I think in a way, PTMC में transeptal puncture is the key. So these
Yes.
would be the different reasons, but yes, you're right that in certain difficult anatomies, I personally, agar fluoroscopic markers in aura, I'll move on to a biplane right atrial or SVC angiogram. And if that's not good enough, then, occasionally transesophageal echo के साथ करना पड़ता है. But in more than 90-95% of patients, आप fluoroscopic markers के साथ बहुत safely कर सकते हैं.
Thank you. That was a very nicely answered. But if you were to get a transeptal puncture, would you get it done by TEE? I know the resource limitation is there, but it does make the procedure much more safer, and there's a targeted puncture. But I totally understand with the human resource that is needed and the financial resource that is needed and the comfort level people have over there, I guess it makes sense that you can do in most cases without requiring imaging. So, Tariq Sahab, your thoughts? He's heading the Pervez Eli Institute of Cardiology. Your thoughts on the talk and the procedure?
Thank you, Numan, for arranging nice discussion about the PTMC. Definitely, it has been said before by Dr. Ramzan also, this is a complicated procedure and there's a very steep learning curve. And in various centers, the results are different. If high volume centers, they are having very good results. And in low volume, definitely they have to use each and every thing to make sure the puncture is the right side. One or two things I must mention it that the operator should perform the echocardiography himself or at least see echocardiography which is recorded because a lot of things you required before in your mind before going to the septal punctures. The important thing is sizes of the two LA and RA and the thickness of the septum is very important. If in normal, our EP colleagues are also doing septal punctures, but that is landmarks is not disturbed. Everything is at right place and they can do the septal puncture whatever wherever they can want. But in PTMC, like the both LA and RA, they are hugely dilated sometime. And in this situations, the operator should be aware about that because as the Ramzan mentioned that in stitch up puncture and in some time if your needle is not facing towards the true septum then slip during the push, it can go up to the aorta, and we have seen some cases here in our center also. So you must be doing echo yourself or at least seeing before the procedure the echo and certain things you must concentrate on that, especially the thickness of the septums and LA and RA size, and then of course the dimensions that makes also. And it is very important. Sometimes it's very difficult to get through the foramen veil, or all the time you're going near to the mitral valve and you have to take a reverse loop. Especially in taking the reverse loop, there is a chance of increase in mitral regurgitations. We are having certain cases in which we successfully done the PTMC. Like at the end of PTMC, what happens because the lie of the balloon in the entrance of the balloon from LA to LV is like this. It is likely to cause the mitral regurgitations, and sometimes we have to get the that patient operated there and then or within the hospital stay because of the significant MR produced by this technique also. So it is very important, and definitely by using other aids make this more easier, more safer, like transesophageal. As Asad Pathan has mentioned that it is very costly and is not feasible for every case. But in some difficult cases, you may arrange anesthesia, you may arrange special our pediatrics colleagues, they are arranging this, so we can perform that. But the ICE is another important and advancement in septal puncture also. We can use the help of ICE. I don't think so in Pakistan we got some centers who have facilities for ICE. We got the machines, but we are trying to manage the ICE catheters. Then we can perform these difficult punctures, especially in difficult cases like kyphoscoliosis, like dextrocardia. We have done some cases of dextrocardia also. Our center is doing like 250 to 300 PTMCs per annum or sometimes we are doing 2 to 3 cases per day also. So we are trying to get this ICE probe also, so that in difficult cases we can be sure about the septal puncture and we can make the procedure easier. And I agree with Dr. Pathan that once you get the right site and the septal puncture, then the rest of the procedure become very easy. Otherwise, you may have to repuncture the septum if you are wrongly puncture the septum. The site is very important, and the purpose of the procedure, as the Ramzan has mentioned, now is not only the PTMC we are doing through septal punctures, we are doing a lot of AP procedures, we are doing mitral valve replacement, we are doing LA occluders. So every purpose of the septal puncture is different, so site is different. So we have to make sure about that, okay, which what is the purpose, and echocardiography should be done by the operator himself also. Thank you.
Very useful comments. Yeah, intracardiac echo should probably make life much easier. We did a lot of PFOSD closures with intracardiac echo guided, and in that you don't need general anesthesia and all that stuff. So it's very useful. And I think the Boston Scientific new machine that is coming out for IVUS has intracardiac probe option as well. Hopefully the price will be reasonable, and the intracardiac echo.
I'll just say, वैसे ICE की price, Noman is typically $1,500, $2,000. So yeah, euros
it's
में.
going to be very expensive.
So
Intracardiac echo probe can
cost
be
की
reused
वजह से
multiple
हम
times.
P avoid कर रहे हैं. I would say ICE would be nearly 10 times as much as P.
Wow. So the only, it's only for the very expensive. Yeah, it's only for our part of the world. Probably we'll never use it. But the only advantage in intracardiac echo probe is that we were reusing it over there as well, because they didn't have the tunnel thing, and there was some policy that you could use it a few times and stuff. They were letting us reuse it even there because of the not having that. So I don't know if that will bring it down, but. So on
Noman, is there time to talk about a little bit? I had a few comments about the talk.
Please. मैंने कहा Dr. Mohammed Irfan भी हैं, उनकी भी thoughts ले लें और फिर then I'll come back to you if the doubt, or you can go ahead and then I can go to Dr. Mohammed Irfan. Please go ahead.
चलो. So I had some points during the talk. Is Irfan talking या मैं बात करूं?
आप कर लें Dr. Irfan के पास एक बार.
Okay. I just जो talk हुई थी मैं उसमें लिखता गया था. I'll start with the contraindication. I think इसमें बहुत ही general बातें लिखी हुई थी. I would say pretty much every single contraindication listed there is relative. In Pakistan में we have to keep in mind कि हमारे local dynamics क्या हैं. In Pakistan, if you start sending 20-some-year-old women for surgery, I think it's asking for disaster. उनको typically metallic valve लगे तो हम सबका experience है कि they frequently come back with valve thrombosis. And अगर आप tissue valve किसी भी type का डालें in young people, they don't last so long. So I think even coronary disease भी हो, even suboptimal aortic valve disease हो, there is Saudi Arabia से registry data के rheumatic aortic stenosis younger people में relatively well respond करता है, and you can defer surgery for an average of 7 years. Tricuspid valve disease भी हो, as long as they're not having a lot of right heart failure के ascites, pedal edema, I think most of these जो ने relative contraindication लिखी थी can be done safely in Pakistan with PTMC. And even अगर unfavorable anatomy हो, moderate MR हो, even if you can get your patient 4-5 years without surgery, that's not a bad option, keeping in mind कि PTMC कितना low risk and simple procedure है. So that's one thing. जो इनने gradient की बात कही थी, I think it's very important. You have to keep in mind कि PTMC से आप क्या expectations रख रहे हैं. There are only two things which determine prognosis in mitral stenosis. आपकी NYHA class 3 or 4 हो या severe pulmonary hypertension. Otherwise, in nearly overwhelming majority में आप symptomatic benefit के लिए कर रहे हैं. There's a very nice paper from Mayo published in Circulation, जिसमें they actually showed that nearly half the people after PTMC did not have symptomatic improvement. And the only predictor they found of symptom improvement was अगर baseline gradient 15 से ज़्यादा था. So I think keeping an eye on the gradient is important on your echo. And I would suggest कि अगर resting gradient 10 से कम हो, my practice is rather than कि बाद में patient tells you, डॉक्टर साहब हमें तो कोई फायदा नहीं हुआ, I always put them on the treadmill and see what their PA pressures do and their treadmill gradients do. If the gradients go over 15, or if the PA pressures go up to 60, 70, then I would advise them PTMC. Agar gradients nahi बढ़ते हैं, then the cause of symptom is something else. फिर एक बात हुई थी विल्कन स्कोर की. मोस्ट स्टडीज ने विल्कन स्कोर को रिप्रोड्यूसिबल नहीं दिखाया, एंड इट्स नॉट शेयर्ड एक्सपीरियंस के हर एक के हाथों में. फ्रॉम द सेम ग्रुप मैथ जनरल से, दैट्स वेयर आई ट्रेन. एक और स्कोर भी पब्लिश हुआ था अबाउट 15 years ago, which was called the ECHO score revisited. We at Tabba call it the Hung score, क्योंकि Judy Hung was the senior author, and they found it a lot more predictable. We used that. उसमें valve की mobility, submitral apparatus, commissural asymmetry, and your beginning valves area सब वो incorporate कर लेते हैं, and it can predict your immediate outcomes as well as mitral regurgitation. LA thrombus की बात हुई थी. I think it's important to keep in mind के ये patient sinus rhythm में भी हो. तो थाईलैंड से सीरीज है कि 7% will have appendage thrombus, so you cannot skip TE. and अगर TE transesophageal echo and your procedure में several days का gap है, that's time enough. People have shown कि इसमें thrombus बन जाता है. So my routine is कि within 24 hours, just for convenience, I don't do it the same day of the procedure, but not more than 48 hours away from the procedure.
That's
Targeted puncture की बात कर ली थी. Wire, the other thing, doing it through a dilator, I don't get the logic of it. I mean, आप एक stiff, आपके dilator और sheath के outer diameter में बहुत ज़्यादा फर्क नहीं है. Just having a soft pliable sheath in the LA is a lot more safer than having a rigid dilator sticking in there and doing an angiogram through that. It allows you to measure pressures and आपके पास ऑप्शन रहते हैं. जो इनने अपने रिकॉर्डेड केस में वायर पोजीशन दिखाई थी, if you saw कि not only was the curly portion curl, but the whole stiff portion of the wire was curled. That is extremely dangerous. That is not for the beginner. That is asking for traumatizing the LA. The whole reason why you have that curly wire is that that is the safe portion of the wire, and don't push the rigid portion in. फिर जो balloon crossing की बात हुई थी, the inner way balloon is made in such a way कि उसकी the tip is most compliant, and आप पहले थोड़ा tip inflate करें तो it becomes like a balloon flotation catheter, and इसके दो advantages हैं. It makes it much easier to cross your mitral valve, and दूसरा it prevents you from going in between the chordae. तो ये जो भी रमजान ने recorded case में दिखाया था कि crossing the valve without any fluid in the balloon, that's dangerous, not for the beginners. दूसरा जो sequential dilation की बात हुई थी, when they use the term sequential for inner way balloon, it's not meant to say कि different compliance है balloon की. It's meant to say कि जो ये size देते हैं, size matrix के, let's say 28 का inner way balloon है, तो it can go from 24 to 28, 4 minus से लेके. And the whole idea is that you start with a lower than your targeted size, and each time you do an echo in the cath lab, make sure there is no MR. आपके दोनों commissures uniformly open हो रहे हैं, and keep going up and do sequentially larger inflation. That's what the sequential dilation starts for. And finally on MR, actually commissural MR ho mild to moderate, the people have shown that's a good sign. That means कि आपके commissures अच्छे dilate हुए हैं, and you generally get larger valve areas, and you get longer time periods without restenosis. The dangerous MR is कि जहाँ पे आपकी uneven leaflet involvement है, some portions are thick, some are thin, and वहाँ पे leaflet tear हो, that's the bad kind of MR. I think थोड़ा सा MR का incidence आजकल अगर आप sequential dilation कर रहे हो, yes, you'll get moderate to severe MR in up to 10%, but need for early surgeries these days is 1% or less. मुझे मेरे मरीजों में MR हो रही थी. I went and spoke to my ustad and boss, and I told him, he said, is it more than 10%? I said, no. Then he said, why are you worried? It's part of the procedure. So I think you have to not be afraid of MR. I know some institutions में MR से डरते हुए they underdilate the valve. Then you're committing the patients to earlier restenosis, and when they come back for the second time, it's not the same valve. Longer time period हो चुका है, आपका further rheumatic process, initial balloon injury से more inflammation, the valve's a lot more degenerated. The first time you do it is the best opportunity. And I think it behooves us, and we are morally responsible that we try and do the best possible job. जैसे coronary stent में आप stents को under expanded छोड़ेंगे, you have higher restenosis, higher stent thrombosis, and you would try and expand it as much as possible. It's the same with mitral balloons. Okay, you try and safely get as big an area as possible. Thank you.
Thank you, Asad bhai. Very insightful comments, and as academic as always, covered Sara kuch very nicely. That Dr. Mohammed Irfan Sahab, your thoughts on the talk and procedure and your comments.
Thanks the organizers, and thanks Ramzan for a nice presentation, beautifully supported by videos. And thanks Dr. Asad Pathan, who has made my life easy. Ab to charaghon mein roshni hai hi nahi. So the one thing which was discussed was the septal puncture. So basically, we at Peshawar, majority of operators, we go through the PFO, and that probe patency help us a lot. There is most of the time we even don't introduce the needle. Needle is just a little behind the tip. So we just probe the thing, and for locating, we come from the SVC with second dip. We just locate, and just with a little bit of pressure, the thing goes in without introducing the needle. So majority of this is the PFO entry rather than puncture. Still, the puncture, the other query which was discussed was the loop, the reverse loop. Reverse loop, yes, there is the chances of MR in that are there, and especially there are leaflet perforation. But for that you have to introduce the stellate. That needs a little bit of experience. That you introduce the stellate and play with the stellate so that the balloon looks down rather than facing up. If it faces up, then it will hit the anterior leaflet of the mitral valve. So as Asad Pathan sir said, that if there is an MR due to leaflets, that will be far more risky than having an MR due to commissures. So commissures we want to open, and we may have MR due to commissures. The other thing was when they discussed regarding the gradients. The gradients, we did a study with heart rate, variable heart, at various heart rates, we had different gradients, and we proved that this may not be a reliable criteria for taking this. So the planimetry is the best method. And still the planimetry should be at the mitral valve tips than above, because if you take it at the mitral valve leaflets level, then it gives a larger area. The other thing is if we take it in AF, sometimes the valve is open, the diastole is shorter or longer. So in a short diastole, we may not have an open valve. So we should take the area in 2 or 3 beats, and then we make an average of that. So if any other queries, so I'm here, and there are expert and panelists are there. So thank you.
Thank you.
Numan, a couple of things इसी में एक कोई valve area and gradients. I think जो सबसे current iteration है echo में valve assessment mitral valve, they made valve area less than 1.5 as severe. So अब ये सारे valve get reported as severe MS, and they might have valve areas of 1.3, 1.4, and mean gradients of 4, 5, 6. Not all of those are severe MR, severe MS, And I think that needs sorting out. And that's why it's important you do further testing to differentiate who will benefit from your mitral ballooning and who will not benefit from mitral.
I think as you mentioned, exercise testing to follow up on the gradient, the pressure is very useful. But आपने कहा था कि 15, there was a study with 15 millimeters AG gradient. That's a pretty high gradient.
Exactly that, but that's a cath lab gradient. Cath lab के अंदर resting gradient, echo में obviously थोड़ा कम होएगा. So that's why I said कि अगर resting echo में 10 से ज़्यादा है and patient को symptoms हैं, then I think it's fine to proceed. But अगर 10 से कम है, then maybe you need to think more. और दूसरा जो reverse loop की बार-बार बात हो रही थी, अगर if you do a reverse loop and you have the balloon tip inflated like you're supposed to have, you will not pass through the chordae. And the way the reverse loop works, okay, once you have crossed the mitral valve, LV apex में आ गए, you inflate the distal tip fully, and then you can actually pull the loop out. पर आप पूरा loop जो LA में reverse होता है, पूरा pull out होके हो जाता है, and then the in a way balloon position becomes like जैसे आप normally cross कर रहे हैं. And uske saath it's no different from crossing it the other way around. So I think the key thing is that you cross it with the balloon tip inflated.
Sir, actually, when we pull it, it automatically unloops.
That's what I mean. I totally agree.
The other thing regarding the gradients, sir, actually the guidelines are prepared by the West, and there the gradient is less because there is the mitral stenosis occurs in elderly, and then there is LV diastolic dysfunction, and there is a little bit of high LV EDP, and due to that probably we have a little bit of lower gradient. Moreover, these patients are the heart rate is slowed down by most of the for most of the patients, and that's the reason that they have less gradient.
Just sorry, one last thing. आपकी practice में भी होएगा, certainly at Tabba, getting patients referred for PTMC in their 40s, 50s, 60s is not uncommon anymore. Maybe public sector hospital में 20s में or teens में or 30s में आ रहे होते हैं, but when you're dealing with these older patients, I think this becomes more relevant, as you yourself said.
बिल्कुल, those are the aspects to cover as keep in mind as well कि elderly में LVDP वगैरह बड़ा और सारा, तो gradients may not be as high. तो उसमें I think with that, any other thoughts, Tahir Saab? We'll conclude it. I think Zubair Saab is the president of our society, is here with us. We'll get some closing remarks from him, 2 minutes closing remarks, and then we'll wind up the session. Zubair Saab?
Numan, one thing I want to mention here also. Zubair Saab, basically, Professor Zubair is our teacher, and we learn a lot from him, especially in PTMC. He got his own techniques and tips and tricks also. One thing is that I am noticing that we are not following the post PTMC. We are not having prophylaxis treatment for that. I think that is why we are getting recurrent rheumatic fever, or sometime the inflammation in the valves also, or we are getting earlier stenosis in the patient also. As a society, we have to decide also what should be the regime, because the injection is not available in Pakistan, although it's very cheap, but it's not available, or they are having some problem with the injection also. That is why people are not using prophylaxis after the PTMC, even they needed it, and they are coming back with the restenosis also. Thank you.
Actually, can I ask a question here for the rest of the panel? आपके 40 plus patients आ रहे हैं, what do you do for the, let's say अगर injection was available, तो आप उनमें prophylaxis की क्या? Do you do it for another 10 years? Do you count PTMC as the last episode of rheumatic fever? या किस तरह से decide करते हैं? ये जो guidelines में वो तो है कि last episode of rheumatic fever say 10 years, yeah, up to the age of 40.
Yeah, up to 40.
Yeah, if you have other, but अगर आप PTMC करी 35, 40, 45 में रहें, तो what do you do about the prophylaxis अगर injection available भी हो? That's a question for the rest of the panel.
And please go ahead, Irfan Saab, Tariq Saab, Zubair Saab, any thoughts on that? कि किसी को आप lifelong consideration देंगे after 40 as well? Guidelines
No.
में lifelong का भी जिक्र है कुछ लोगों के लिए जी.
So after 40, I don't think there is any need for injections.
Okay. Tariq Saab, Zubair Saab, आपकी thoughts? After 40, would you be giving prophylaxis?
Not really. So, can I go with my comments?
Please. Final
Thank you
thoughts
very
by
much.
Zubair
First,
Saab, he's the president of First Society. And
thank you very much, Naman, for a wonderful session. और खास तौर पे Ramzan, I'm really impressed. It should be on the PSIC website also, so that जो लोग अभी शामिल नहीं हो सके, जो landmarks and all that, what he showed, they were really great. अच्छा, मतलब out of the rest, maybe I am the only fortunate one that I was teached by Innoy, the PTMC, in 1995. We came twice in 1994, 1995 for this PTMC procedure. और obviously उस वक्त भी काफी prevalent था. Still it's quite prevalent, as Tariq Abbas is telling. Obviously is maybe doing 2 or 3 per day even, or around 300 plus per year. And what we saw was it's mostly the females which have been affected by this rheumatic fever and this mitral stenosis, especially in teenage. और जिस तरह से कह रहे हैं, obviously 40s 50s में है, but they are very rare and mostly it's the younger age group. Or regarding, first of all, few tips, Baki though everybody has really elaborated on the topic, but a few tips here. First of all, the selection is very important. And, whenever we used to select and still we select, obviously a good echo is very, very important. And for me, a short axis view for selecting a PTMC case or balloon valvolectomy case is very important. And, in the short axis, just तरह के Ramzan ने बताया, obviously it's the commissure and the leaflets where we are targeting. If the commissures are calcified and the leaflets are thin, obviously it's a very high risk morphology. We may or we may not, accept a case where there is a severe calcification and a very thin leaflets, or maybe a punctate calcification of the leaflets, anterior posterior, because these are the ones where complications are likely to occur. So short axis is very important, and obviously with this good short axis view, and we take the pics out of that, picture भी ले लेते हैं ताकि बाद में हमें याद रहे कि इसके commissions का क्या सूरत थी. Regarding puncture techniques, obviously as Tariq has showed, obviously me and Tariq Shafi, we developed our own puncture techniques, and usually we puncture, in LA 90, and obviously with the septal staining technique also, वो आपको कोई बाद में बताएंगे, and obviously then we puncture it. And regarding this, after when we are puncturing it with the broken bro needle, obviously there is a tip, obviously, which Ramzan didn't mention. Obviously, the broken bro needle के आपके पीछे जो है, there is a pointer, and this pointer, this has to be a pointing between 4 to 6 o'clock. So that's the best pointing direction, so that you are accurate, and then you puncture this one. And obviously regarding balloon, obviously उसको किस तरह unlock करना है और फिर उसको lock करना है किस तरह retrieve करते हुए, that's very important. Or regarding T, obviously we never used to do it, obviously because of feasibility and all that. Or even on-site echo जो है, obviously for us, obviously जैसे ही we would cross, और भी फौरी तौर पे हम baseline जो है LA pressures ले लेते हैं, और उसके बाद once we are doing it, obviously stepwise dilatation is always preferable in high risk morphologies especially. और जैसे ही हम first inflation देते हैं, that's most important, और especially अगर west निकल जाए, the first thing we use to do it and still do it is फौरी तौर पे LA pressures लेते हैं. पहली बात है कि क्या LA प्रेशर ड्रॉप किए या नहीं किए, क्या राइज तो नहीं हो गया, और स्पेशली द वी वेव. अगर आप वी वेव प्रोमिनेंट हो गई है, रेस्ट अश्योर्ड दैट यू आर encountering a MR, और अगर प्रेशर्स बढ़ गए तो immediately you have to bring the echo machine and to see MR, और अगर MR ज्यादा है तो obviously you stop dilatations there onwards. So all in all, I think बाकी तो सब पूरा डिस्कस हो गया, and it was a wonderful session, and Namaz, you are doing a wonderful job for this as in charge of this academic committee, and wish you all the best for the future lectures as well. Thank you.
Thank you, Zubair sir. Very useful closing remarks. Somehow, Fizan साहब check कर सकते हैं कौन देख रहे हैं इनका, कि कुछ questions हो from the audience. वो कह रहे हैं कि शायद audience के लिए वो questions वाला portion disable हुआ है, तो अगर कोई उनके questions आ रहे हैं तो जरा बता दें ताकि वो we can close with that. ये अपना एक्टिवेट कर देते participants के लिए questions उन्होंने डाला हुआ कि उनका वो inactive हुआ है, they can't put in the question there.
डन है सर, मैं चेक करके करता हूँ सर।
But अगर फौरन बता दें, कोई questions आए हुए, किसी ने आपको text किए हुए questions वगैरह तो बता दें।
Noman, I have checked the chat. There is no question so far.
वहां पे नहीं थे, बट किसी ने ग्रुप में डाला हुआ है, मास्टर्स वाले में किसी ने कि जी स्टिल चैट इज डिसेबल्ड फॉर द पार्टिसिपेंट्स, तो पता नहीं शायद वो डाल नहीं पा रहे, तो मैं इसलिए का पूछ लूं बिफोर क्लोजिंग अगर कोई क्वेश्चंस हैं किसी के।
Sir, I have activated the chat, but they haven't asked anything yet.
So while they're looking that up, Noman, I'll make a comment about calcified valve. So actually, French registry said they've shown it very nicely. Okay, moderate to severely calcified, and this is angiographic calcification. You can get good PTMC result in 85% of patient, and severe MR ki risk is only 2-3%. And they define good result as valve area more than 1.5 and less than moderate MR. I don't think that's a bad option. And again, I keep saying, and in fact, abhi Khan mein meeting ho rahi thi, I was really pressurizing the surgeons ke why aren't they doing more repair in these rheumatic valves and valve sparing surgery. And until that time comes, I think we should try our best कि हमारे मरीजों को OR भेजने का हम जितना delay कर सकते हैं करें. I think we should keep that in mind कि sending them to the OR is not necessarily a good option in the Pakistani healthcare. Younger people especially. और ये rheumatic MS वाले invariably young people होते हैं.
बिल्कुल बिल्कुल, हाँ जी. तो how you approach question is how you approach a stepwise increment in inflation. I mean 1 atmosphere or 2 atmospheres, is it necessary to check MR on echo then decide increment pressure? Who will take this question on पहला question ये आया. Asad sahab, do you want to answer that?
Numan, I can take this question.
Zubair sahab ji, please go ahead.
First of all is the high risk morphology. Obviously, जिस तरह असद ने कहा था कि आप 28 है तो आप obviously you need not to use obviously 2 PTMC balloons. High risk morphology में पहले ही आप प्लान कर लेते हो कि how would you proceed with it, और obviously उसमें जो है calcified valves और अगर thickened commissures हैं तो obviously you go with stepwise dilatations. Let's say कि अगर उसका 28 है तो you start with 24 and obviously with each dilatation आप बजाय कि एको करो, द बेस्ट थिंग इज कि ऑब्वियसली वो एलए प्रेशर्स आप मेजर करते जाओ और ऑब्वियसली एक वेस्ट का भी आपको आइडिया होता चला जाएगा एंड ऑब्वियसली दैट विल गाइड यू कि आप स्टेप बाय स्टेप. फॉर मी ऑब्वियसली आई ऑलवेज डू स्टेप वाइज के साथ में फॉरवर्ड एलए प्रेशर्स देखता हूँ और अगर एलए प्रेशर्स बढ़ नहीं रहे देन आई मूव टू 25 एंड देन 26 एंड दैट्स हाउ वी गो इट एंड अल्टीमेटली द रिजल्ट एंड इफ रिक्वायर्ड द एको इज देयर टू सी.
Bilkul say, and Samiullah, Dr. Samiullah has a question regarding the imaginary lines for septal puncture. How do you do it practically? Mean you have to draw these lines on the screen, or these are just imaginary? You want to answer it, Asad Pathan? आप answer करेंगे इसको?
So I use this also. In fact, मैंने तो अब 3 planes में I start with AP, go 30 RAO, and then left lateral 90 degrees. I view all 3 views. And I find it very useful. Although आप AP या RAO में से एक भी select कर सकते हैं, but you don't actually draw. Maybe for a beginner आप screen पर draw कर सकते हैं on your fluorostor, but as you get experience, you can see it. But keep in mind कि आप जो वो middle line draw कर रहे हैं जो AP में, कि most patient में left atrium is more medial. But when the left atrium is hugely dilated, it actually becomes the rightmost lateral part of the heart border. So it's not the inner one, it's the outer one. So ये थोड़ा सा एक caveat, but obviously you would know this from your echocardiogram if you've got giant left atria. But you're right, Kate. Once you have a little bit of experience, so you can just visualize it in your mind.
Numan, इस पे हमारे एक्सपीरियंस में when we went from Illinois, obviously lines हम draw करते थे, but आप जिस तरह आप जो टेक्निक है आपका, जिस तरह आप पिक्टेल आप रख देते हो एलए में और उसमें आप एक व्यू में जाओ तो obviously with the spine and the pictal there, obviously imaginary line के साथ you can easily do it now.
अच्छा ठीक. So इसमें next question was regarding reverse loop technique. What are the indications to use this? And secondly, what is exact area of septal puncture in PTMC? It can be simplified for beginners. Tariq Saab, you want to take that one? Tariq Saab, are you there? Zubair Saab, you want to take that one?
Actually, Numan, obviously, it just depends. कई दफा there are two sorts of problems which may encounter. जैसा रमजान ने बताया था, कई दफा आपका पंक्चर बहुत इंटीरियर हो जाता है, वहाँ अलग प्रॉब्लम है. और obviously reverse loop जो है, obviously it's because of the large LA. And obviously, once you get into this or normal PTMC में जो है, आप स्टिलेट अगर आप डालते हो, उसको थोड़ा सा विड्रॉ करके you go anti-clockwise. Anti-clockwise और थोड़ा सा balloon inflated के साथ आप करोगे, then it will get into from LA to LV. But if the LA is too large, obviously this technique won't work. उसके अंदर ये है कि आप स्टिलेट विड्रॉ नहीं करते, स्टिलेट को फुल पुश कर देते हो टू द टिप ऑफ द PTMC balloon. और उसके बाद rather than टॉकिंग इट एंटी क्लॉकवाइज, आप उसको क्लॉकवाइज रोटेट करते हो, और क्लॉकवाइज रोटेट करके आप जो है पूरा एक लूप बना लेते हो एलए के अंदर. एंड दैट्स द टेक्निक फॉर दैट. और उसके बाद फिर जब आप लूप बनाते हो, वो तो टुवर्ड्स माइट्रल वाल्व एनुलस जो है वो डायरेक्ट होना शुरू हो जाता है. एंड देयर ऑनवर्ड्स, जिस तरह के अल्फाज साहब भी कहा, यू स्टार्ट इन्फ्लेट करो, और उसके बाद वो इट स्टार्ट फिटिंग इनटू डिपिंग इनटू द एलवी. और उसके अंदर जब आप विड्रॉ करते हो तो वो बिल्कुल स्ट्रेटन हो जाता है एज इट इफ जिस तरह के रूटीन में हम करते हैं. सो दैट्स फॉर द लार्ज एलए. एंड हियर you have to push the stiletto to full length and then do clockwise rotation to make a loop.
Okay. Hopefully
एक इसमें ऐड करता हूं. अगर आप बहुत ही लो या इंटीरियर पंक्चर करते हैं तो उसमें आप कर्व के साथ जा नहीं सकते, तो वो ऑटोमेटिकली लूप ही करेंगे तो जाएंगे. अगर आप बहुत ज्यादा हाई करेंगे तो उसको आप लूप नहीं बना सकते. This is automatically, these things are made when you are practicing things. So you will automatically, if it is a low puncture, you will try curve and it will not be going. So automatically you will loop. If you are doing a high puncture, you try to make a loop, reverse loop, but it will not be made. Automatically you have to go with a curve. So these things are there on the table. You decide whether it is too high or too low, interior, posterior, and whether I should loop or curve. It will automatically be made.
But I think इसमें जो for the puncture जो beginner के लिए, कि जैसे जो RA व्यू में describe किया था, if the tip of your needle is closer towards the pigtail जो descending aorta में है, यानी closer towards the spine, so you're a little bit more posterior, so that's preferable. और फिर दूसरा आप है ना lateral view में जो आ रहे हैं, तो इनने बताया था कि posterior hard border and pigtail in the aorta, तो वो जो line he said 1/3 middle 1/3, I would recommend more के 2/3 from the aorta and 1/3 from the posterior hard border. तो this way आप थोड़ा सा posterior और low puncture कर रहे हैं, not too low, and this would be ideal for a balloon. तो puncturing के लिए this would be, अगर आप fluoroscopic markers, अगर beginner के लिए if you confused then या अगर LA is बहुत enlarged, then either refer the patient somewhere else or do it with TE guidance. TE में बहुत आसान है.
The next question is by Jabbar Ali. It is almost, and we sometimes see patient with moderate MR before PTMC. And after PTMC, the MR is reduced. Any thoughts on that? Okay. In your experience, any of you guys have seen that? MR reduced PTMC?
So this was actually published. किसी ने एक छोटी सी case series publish की, about 30 patients or so, and के moderate MR के साथ and doing PTMC, and you can safely do it as long as your mitral valve is very pliable and favorable. तो अगर आपके commissural asymmetry नहीं है, बहुत thick calcified leaflets नहीं है, and in some of these patients, because your valve mobility improves, तो आपका वो जो restricted leaflet की वजह से MR होती है वो कम हो जाती है. So you can safely do it without increasing MR, and in a tiny proportion, the MR might actually reduce. That's the mechanism.
Okay. Thank you. And the next was residual left to right shunt.
आजकल unheard of. आजकल unheard है.
I've not heard of किसी को close confusion.
Yeah, क्योंकि आप आप 14 French dilator से कर रहे हैं, which is less than 14 तो dilator size is stretched, और obviously आप dilator निकालते हैं, equipment निकालते हैं, तो septum दोबारा से थोड़ा shrink होता है. So you're just leaving a maybe 3-4 millimeter hole. तो अगर ये हो भी, it's not an issue. The only time, the rare time it can become an issue if you've got severe tricuspid stenosis and your right atrial pressures are very high. There are case reports कि अगर आपने mitral valve को पहले address किया है, and then you try and you don't have equipment in place, you take your mitral equipment out, the patient suddenly gets a large right to left shunt because your RA pressures now become higher than LA pressures. So what's recommended in this rare situation is कि आप पहले से RVOT में wire डाल के रखें ताकि you can quickly slip in your balloon and do a tricuspid dilation. But outside of that, residual left to right shunt, need to close it, अब not required. आजकल बहुत पहले जब डबल बलून करते थे, 2 punctures कर रहे थे, your balloon profiles were higher, you were dilating with 6-8 millimeters balloon. जैसे percutaneous mitral valve में they actually dilate with a 14 mm balloon. Your atrial septum, so obviously you have to close it afterwards. But आजकल PTMC में it's unheard of. I've not had or heard of a single patient requiring.
One addition, sir, for this. If the balloon is not properly slenderized, so in that case, the balloon may just wrinkle and may cause a more severe left to right shunt. It will rather create an ASD. If the balloon is not properly slenderized, the stillets, the stretching tubes are not properly.
You're taking it up, बिल्कुल. So
another इसमें एक key thing is कि आपका जो curly wire है, you should actually, while your balloon is still in the left atrium, you should pull most of your curly wire out ताकि just your tip is sticking out, क्योंकि otherwise अगर आप balloon को withdraw कर लेंगे, now when you pull on the curly wire, you might have a cheese cutter effect with the curly wire. So I think Dr. Irfan ने सही कहा है कि if you use poor technique, yes, you might traumatize the atrial septum and have large shunts, but if you're using the proper technique, it should not have.
So there are a bunch of more questions. We are running out of time. So quickly, 1 minute answers. Oblique septal puncture, thick intra-atrial septum away lead to difficulty for crossing the balloon. Any thoughts on that? Any of the panelists who want to take that question on?
I think oblique puncture to nahi hota, but yes, occasionally you do run into thick septum, and you might have
or thick intra-atrial septum may lead to
thick intra-atrial septum. तो आपका जो broken broad needle आती है, it actually comes with a stylet which is meant for this. It gives you more pushability. You can electrify, put a wire in it, और जैसे कि आप basilica में electrify करते हैं, you can electrify even through a broken broad needle and puncture. And if you can't cross your sheath or dilator, and you can get your curly wire, sometimes you need to, I've had to do it several times कि आपको 6 millimeter के peripheral balloon से atrial septum को dilate करना पड़ता है, but that's occasionally required अगर आपके thick fibrotic septum हो.
Actually, the oblique septal puncture is.
So I've seen a versatility wire ko. Okay. Yeah, try to you guys always try to go through the PFO, बिल्कुल.
Yes.
So जो आप electrify कर रहे हैं, broken broad की बात करें, how did you do that? I mean, they have VersaGold wire up, safe cross, huh?
Oh, it's the same as basilica. जो आप Terry में basilica में electrify करते हैं, so you just put the tip of your wire and 014 back end wire, उसको मार के and दूसरे end से electrify कर लें, you can do that. People have done this, so.
So उसमें or any tips for with LA thrombus, left atrial appendage thrombus? Do you actually do it with the left atrial appendage thrombus? उसमें था, it's a relative contraindication, but any of you do it with the thrombus in the left atrial appendage?
I've done a few, but very selected. If you can't wait, ideally I would always try. एक तो I think again for trainees, अगर LA body में thrombus है, not
And any
appendix,
particular tips
body, it
to
will
avoid,
not go away.
uh,
So I think ऐसे patients को upfront surgery के लिए भेज दिया करें. Appendage thrombus and it's limited to the appendage. If you don't have time to wait या आपने 2-3 दफा defer किया, दूसरी तीसरी TE पे आ गए, I would do it, but you have to be very meticulous with your technique. You have to make sure कि आपका no part of your equipment goes towards the appendage. आपका NOA balloon जब LV में हो, when you're taking it out, तो आप stylet को advance करके clockwise rotate करके then pull your balloon out of the LV. That way, instead of going anteriorly towards the appendage, it will point in the opposite way. So yes, you can use these tricks, but it's not for a beginner or intermediate operator. I think I would advise most beginner intermediates to avoid LA thrombi.
And the other question is, facing difficulty of PEDS patient of heights less than 143 centimeters, how you approach these patients as balloon less than 24 is not available. तो ये कोई PEDS patient के ऊपर कोई कर रहा है तो अपनी thought share कर लें.
24
less than
balloon you can
143
start at 20.
These PEDS patient.
24 balloon goes from 20 to 24. So वो अगर 140 से कम भी है, you can do it. And if you're doing a lot of these, if you're doing a lot of these patients, then talk to the distributor and specially order smaller balloons for your institution. I think that's an option.
And how will you manage undeflated inner balloon? That's the last question at mitral position.
I think दुआ करें and surgeon को बुलाएं.
But ठीक है.
I don't know. It's a very challenging. I've heard of uninflated in LA, but across the mitral valve, you can push it. You can push the balloon and get it into the LV ताकि आपकी circulation restore हो जाए. I think rather than circulate the rest, I would accept severe MR. तो अगर push करना है या pull करना है, just get it out of the mitral valve. अगर आपने balloon को inflate, deflate several times कर लिया है, you can try and rupture it by inflating more. But obviously keep in mind कि आपका जो balloon inflated है, जो लोग भी mitral valvuloplasty करते हैं, you take more than 4-5 seconds in your inflation deflation cycle, patient starts seizing. So they basically have circulatory arrest when you're doing that. So अगर आपका balloon का inflated position में, you have to really act quickly क्योंकि you only have a few seconds.
You can just try with because that's almost
On that, we'll end.
तो इसको मेरे ख्याल में स्ट्रेचिंग ट्यूब, अगर आप स्टील स्ट्रेचिंग ट्यूब को बगैर उसके वायर के अगर आप एंड करें तो बैलून रप्चर होगा एंड देन इट कैन कम आउट.
ठीक. So very insightful comments and excellent talk. So I learned a lot from it. And आप किसी ने पूछा होता कि sessions available होते हैं कि नहीं होते? They are available on the website, and we'll try to update. सारे नहीं हुए updated over, but we'll make sure that they're updated on the website as well. So thank you again to the speaker and the panelists, for joining and taking the time out. So really appreciate it. And on that note, we'll end and have a nice weekend, everyone. Khuda Hafiz.
Numan, thank you so much.
Thank you.
Thank you again. Thank you.